Final presenter for this first session is Jasmine Sowers. As if it were not significant enough to start one organization, somebody had to be an overachiever and start two, in an effort to make sure that as we lift to the moon, right, within this moonshot, that young women, young black women, are not left on the ground. It is my privilege to introduce Jasmine Sowers, who will be presenting her research, Women of Color, Increasing Women of Color Representation in Breast Cancer Clinical Trials. She is the CEO of the Missing Pink Breast Cancer Alliance and the co-founder of For the Breast of Us.
Thank you so much. I first want to say there's so much Black girl magic in this room and on this stage. It is just an absolute honor just to be in community and to be here with all of you. But I'm excited to share a few of the highlights from the study we did on race, culture, and the perception of clinical trials. I led this study alongside Marissa Thomas, who is the co-founder and CEO of For the Breast of Us, with our partners at Summer Consulting. And this all stemmed from one conversation about what Summer Consulting could do to make the greatest impact in our community. For the Breast of Us is the first online community for women of color affected by breast cancer. And just a little history about why this idea was started. Marissa and I were in a meeting about that lack of diversity in clinical trials. And this was being led by a prominent researcher. And her response to Black women and women of color not participating was, they just don't show up. And the room got hot. Because how could you meet a dire need? Women are dying. And the response is, they just don't show up. And it felt like they didn't care. So in that meeting, I said, well, if we need to do something different, I'm happy to lead that. And Marissa said, whatever you do, I'm down. So that's how we came up with For the Breast of Us. And that's why we chose clinical trials as the place where Summer Consulting can help us make the greatest impact. Now, we believe that complex solutions require complex problems require collaborative solutions. I'll say it again. Complex problems require collaborative solutions. So when we set out on this study, we didn't just want to focus on problems. We've talked about problems for decades, guys, and we're in the same place. So if we had a conversation about diversity in clinical trials, we wanted to examine what could we learn from those challenges and how could they inform the ways that we work differently in the future. And that's what we did. So we took a different approach to this study. I'll take a moment to define terminology because terminology is important. So when I say Black women, I'm talking specifically about Black women. The term women of color is a collective term for non-white women. They are not interchangeable. So when you hear me say women of color, I'm talking women of color. Black women, I'm talking about Black women. That's important. But this study actually looked at all women. It looked at all women, and it looked at women that were diagnosed with breast cancer and were not diagnosed with breast cancer. We did this in 2 phases, a survey and an interview. And we focused on 3 things. Healthcare experiences, clinical trial understanding, and clinical trial barriers. Misdiagnosed, drug seeker, inadequate care, and dismissed were the common themes for Black women as they talked about their experience with breast cancer. And that's kind of sobering because I wasn't in the study, but that was my experience too. So we start to look at the experiences of Black women, the mistreatment of Black women as the rule instead of the exception. And this project has so much great data. If you look in your folders, you'll see we have a 1-pager, and that 1-pager has a QR code. On that QR code, you can look at the final report with all the numbers, but it was really hard to find like a couple of things to really summarize all the greatness in that study. So I'm really going to hit some of the high-level points and perhaps maybe things that my colleagues have not pointed out. One of the things I thought was most exciting about the data regarding healthcare experiences is we've done a lot of talking about how Black patients prefer Black providers. And I'm not going to say that our study necessarily didn't have a little bit of that in there too. The difference is we looked at race as a trust-building factor. And we asked women, What are elements of trust when you are considering a provider? Their response was overwhelmingly willingness to listen, bedside manner, and shared decision making. So we went back to that group that did say, no, race is absolutely a trust building factor. And we asked them, when you can't control for race, what elements help you build trust with your healthcare provider? And they said, willingness to listen, bedside manner, and shared decision making. What I appreciate about this line of questioning is that it shifts us from something we can't control. Doctors can't control their race, and quite frankly, their race and our race should not dictate our ability to get high quality treatment. But now we're focusing on things that can be addressed through staffing, through culture, and through training. In the numbers regarding clinical trial understanding, even women who showed a greater understanding were not proactive in initiating the conversation regarding clinical trials. And there were a few common assumptions that these women had. They tend to believe that only doctors share information regarding clinical trials. They think people with money are the people that can participate. And what's interesting, which is why if you are a fan of the targeted universalism approach, which sets one goal and then measures how different communities are measuring to that goal. And then it implements different strategies to help each community meet that goal. You'll really appreciate the findings in this study. Because an interesting thing about that notion that Black women believed only people with money could participate, white women said the same thing. White women said, this is something only people that are connected can do. There's also, again, the last resort narrative, the placebo means no treatment narrative, and that they require travel. And for a second, I want to go back to this idea of having to be connected and having to have money to participate in a clinical trial. Because I think in some ways, when we talk about clinical trials or in some messaging, we've talked about them as luxuries, right? The best strategies, I'm going to try to move away from the term interventions, and I'll mention that in a minute, but the best strategies are designed to meet the unique needs and challenges of the community that you serve. And I think that messaging is a great example of that, because in a community where someone has the means to afford a Cadillac, and you say this is the Cadillac of care, that sounds right on par with the rest of their experience. But in a community where people are struggling to access basic needs, saying that this is the Cadillac of care, I mean, you are offering me something that is just beyond my reach. The third part of our study was clinical trial barriers. Most of these things should not surprise you, but there are a few things that I want to point out. One of those is the nuances in financial assistance as an intervention. When we typically talk about cost of participation, we talk about insurance, cost of labs, cost of scans, but even though time off work is considered a logistical barrier, that also then becomes a finance barrier. The same thing with childcare. And so I think we have to be a little bit more holistic in the way that we think of using finances or supporting patients with finance interventions. This last barrier on the importance of trust and knowledge, can you believe that approachability and getting questions answered were greater barriers than finding trustworthy resources? Approachability and getting questions answered was considered a greater barrier than finding trustworthy resources. And when it came to logistical barriers, we saw that there was an interesting approach. So our researchers noticed that white women talked a whole lot about transportation. And when they went back to see why white women were talking so much about transportation, it's because when white women were presented with barriers, they then had the capacity to start thinking through solutions. We didn't see that same response in women of color. In fact, oftentimes women of color were approaching barriers and then they would disqualify themselves. There wasn't a lot of effort to push past that. And I know when we say things like they're not putting the effort or they're not trying, they're not fighting to get access, And we mentioned things like they're not being proactive in the conversations. Even the most well-intending people may start to feel that they just don't care, right? They don't care. And with that notion, I really want to challenge you. If this thought is going through your mind, think about how much of the Black experience has been centered on having to fight for things. We have been fighting to live at the very beginning. We fought for access to schools, access to care, access to jobs. We are always fighting, and we have almost normalized Black people having to fight for things that are so freely given to others. So this isn't about developing strategies for people that don't want to help themselves. This is about understanding the impact of our race, our history, and our lived experiences, how that shapes us into the people that we are, and how those things impact the opportunities that we have and the capacity that we have to go further in life. And we're supposed to be meeting people where they are. So that's where all of this really is stemming from, right? So where do we begin? I think the best place is for us to realize that we cannot advance equity in silos. How much research has been done that has demonstrated the same barriers exist in all parts of care? They're not unique to clinical trials. We see the same things in genetic testing and general access to care, and yet we continue to develop interventions for those specific things as it's not the whole thing that's the problem. This is why I want to be mindful about using the word intervention, because I feel like if we continue to create interventions in silos, we will do nothing but support a broken system. We are continuing to recycle something that needs to be replaced. And I'll give you an example of how this looks like from a patient perspective, right? I used this research actually as a patient advocate on a clinical trial for triple-negative breast cancer, with the understanding that I knew what the barriers were. I knew that women weren't going to be forthcoming if they needed help. I knew they weren't going to be forthcoming with questions, and so we redesigned a one-pager with all those things in mind. Time is an issue. This is how much time you have to put into this. Location is an issue. Virtual enrollment. This opens up a whole door, right? But then I'm also a patient for that same network of hospitals. And this honestly was the first time that I realized this. I walked into my appointment in the breast clinic, and I turned around, looked at the brochures, and they were all white women. And then I thought, how often do I see Black staff here? The person that manages the parking garage, and the person that does the scheduling from time to time. If you are already coming into a situation not trusting people, what does it look like to walk into spaces where the only place you're represented is on the front of a clinical trial flyer, right? If we are going to advance equity, it has to be a lens. It's not a one-off. It's not an effort. It has to be the way we do everything, not the way we do this one thing. And again, patients aren't being asked. Messaging is important, but when we have these conversations, and we need to be initiating these conversations, we also need to be proactive in presenting resources that help patients overcome these barriers. Let's anticipate challenges, right? And again, this depends on the community that you serve. The best strategies are going to be built on the data and the needs of the community that you live in, that you're serving. And then my last note is, I've always been a fan of the idea that equity lives and dies in policy and procedure. While implicit bias trainings can show people where their faults are, they don't guarantee a change in behavior. And so you really go back to policy and practice, and not just at a federal level, but in the institutions that, where Ricky, work, play, slay, all of that, the places we have realm of influence, we need to be looking at the policies of those places and the practices of those places. But the rule book does not dismiss the need, or does not dismiss the fact that this is a very human experience. Our patients said that they would be more willing to forego treatment at places where they had better treatment or more access or more resources. They were willing to forego that if they could just be with people who understood them, right? So yes, we need to rebuild. We need to make a new baby, Ricky. We need to make a new baby, right? We need to be checking our policy and our practices. We need to be using equity as a lens for everything we do. But then we also need to be mindful that, well, let me first say this. Black Women Speak, if you think about it, Stephanie, I'm not sure where you got the name from, but I've been saying for years that Black women are dying to be heard, and so it's such an appropriate title for this event. And like I said earlier, race, the race between the provider as a trust factor, yes, that's a thing, but if you look at the heart, we're asking to be treated as humans. We're asking to be treated with dignity, with respect, and with consideration. And so it's not just fixing the policies, we have to fix the people as well. That's it.